Hi, good morning, good afternoon, good evening. Thank you for joining us at our site presentations from the Neonatal Hemodynamics Research Center. Today we have the pleasure to be joined by Dr. Lisa Hornberger. She's a professor of pediatrics, obstetrics and gynecology, and she was the founder and initial director of the University of Alberta's Fetal and Neonatal Cardiology program, and currently the section head of pediatric and fetal echocardiography at the Women's and Children's Health Research Institute's Stollery Children's Hospital at Alberta, Edmonton. She's been described by her peers as an amazing clinician and educator. Her research interests are fetal and neonatal cardiology, pediatric echocardiography, general pediatric cardiology. She has more than 100 peer-reviewed articles, and we'll be hearing her talk with great pleasure, and a really interesting topic for us neonatologists dealing with sick babies. For the panel discussion, we will be joined by Dr. Angela Bates. She's a pediatric critical care intensivist at the Stollery Children's Hospital, Associate Clinical Professor, Department of Pediatrics at the University of Alberta, and the Pediatric Pulmonary Hypertension Medical Director at the Stollery Children's Hospital, and also by Dr. Amish Jain, who's a staff neonatologist and clinical scientist at Mount Sinai Health System, and Professor of Pediatrics at the University of Toronto. He's the Director of the Targeted Neonatal Echocardiography Program at Mount Sinai Hospital and one of the founders of the Neonatal Hemodynamics Research Center. For moderating, I will be joined by Dr. Marjorie McConey from the Children's Hospital at Oklahoma University Health Science Center. So, Dr. Hornberger, thank you so much.
Thank you so much for having me. This is a lovely opportunity, and it's great to have more interaction between neonatology and cardiology for sure. We certainly have a lot of common interests, and I have many colleagues that I've done research with over the years. This particular topic isn't necessarily one that I've done a lot of research in, but at least I've had experience with over the years. And that is looking at mostly post-capillary, pulmonary capillary related causes of pulmonary hypertension in the newborn. Specifically, especially with evolving use of and increasing use of TN echo, I think it's really very important for neonatologists engaged in this area to really have a better understanding of the kind of things that they should be looking or excluding, and also just understandings of the pathophysiology of these disease states that can be helpful in managing them. So as a start, I thought I would talk about pulmonary venous pathology, both congenital and acquired, as well as left heart pathology, including left heart obstruction and left ventricular myocardial disease, which can create a situation that leads to pulmonary hypertension. A lot of what I will show you are not other imaging modalities. I'm an echocardiographer, and certainly with the TN echo crowd, I think it's really helpful to increasingly understand how you can use echo to get a lot of hemodynamic information. And even if you're not the one performing a lot of the studies on babies with cardiac pathology, it's helpful to be able to interpret when you're managing these babies, as I'm sure Angela, Dr. Bates can attest. So as a start, pulmonary venous, anomalous pulmonary venous connections, an important thing, an important lesion to be aware of. While rare, it's unfortunately one of the lesions that around the world has some of the least prenatal detection rates. And that's as a consequence of nothing really definitive and consistent that's abnormal in the fetal heart, with the exception of where those veins come in. So unlike postnatally, where you get left-right heart discrepancy, that doesn't happen prenatally. And so unless you're looking at the veins, or unless it happens to be the rare case that has discrepancy, they just don't get picked up. We're trying to change that, but in the meanwhile, these are going to be babies that come through, and some of them will come through as a possible PPHN. And so the question is, can you cut to the chase and figure out that this is this kind of lesion? So there are several different kinds. The ones that you're likely to see are the supracardiacs. That's about 50%. Most of them, the most common, where the left, there's a vertical vein that joins the left innominate vein, being the most common, that ultimately ends up leading to the SVC, or some of them can actually join the right SVC. There are intracardiac types where they either go back to the coronary sinus, which is by far the most common, or into the right atrium. And finally, the infracardiac are the others that you will see because they are many times associated with obstruction, not all the times. Some of them, they go through a vertical vein, through the diaphragm, and join either the portal venous system. Most of those are not acutely obstructed, or the IVC ductus venosus junction, and those can be obstructed. And then there is the really rare mixed type. So, of course, the presentation of these babies depends on the severity of obstruction to pulmonary venous return. This is a classic example of a kind of small heart and very whited out lungs with pulmonary edema. These babies with severe obstruction will have cyanosis, tachypnea. They require ventilation. They can be really tough to treat. They really are surgical emergencies, in fact. And they have severe pulmonary hypertension and edema with onset at or shortly after birth. Our last case, or one of our last cases, in fact, delivered on Boxing Day and ended up on bypass within about 15-20 minutes. We picked it up prenatally, and mom went into labor, so they delivered her in the Mazankowski, and were able to get that little one through. Without obstruction, they're well, or they have evidence of mild CHF. They may come through with having failed an oxygen saturation assessment with cyanosis due to right to left atrial level shunting, and they may have a murmur, but these are often a little bit less obvious. So I'm going to show you the more obvious babies. This is a 1-day-old with cyanosis, not responding to oxygen, and with tachypnea. The baby was not at this point yet intubated. There was right to left atrial level shunting, that's classic, and a small-ish left atrium, and we'll talk about where you're looking for the veins. So that right to left shunt and a small left atrium. This baby, otherwise, if you didn't look for the veins, you would say, oh, this baby has PPHN or has pulmonary hypertension. The septum is flat or bowing into the LV. The LV on the forechamber looks underfilled, and that's mostly because a lot of flow is going through the right heart, plus the high pressures in this baby on the right heart side. You can see a complete right to left ductal shunt, and the importance of that is because the pulmonary venous blood is going through the PA and then through the duct. In fact, you get that reversed pre-post ductal O2 sat difference with a higher oxygen saturation in the post-ductal area. One of the very few things that actually gives you that. Another defect is transposition with pH and I think sometimes coarctation as well. So this is what you're looking for. So there's a small LA, big RA, right to left shunting, but you're seeing this little confluence, and sorry it's so bright, seeing that confluence sitting behind the left atrium. There shouldn't be anything you really see behind the left atrium, maybe the descending over here, but you're seeing this structure right there. And in fact, I can follow this structure down with this tube that's ultimately in this baby come back to the IVC ductus venosus area. So this is actually the vertical vein. This is the confluence bringing blood down. So by color, if you're throwing your color and you're seeing it, the structure coming down that should not be doing this. What should be coming your way should be the descending aorta, which you're seeing up here pulsating, but this is actually coursing through the liver and joining the IVC probably through the ductus venosus here. And at that level, there's a significant amount of obstruction, as you can see here, with very high continuous flow velocities. And the other clue to obstructed veins is that your pulmonary vein flow profile is very abnormal. You see how it's very low velocity, very monotonous. It's very classic for obstructed pulmonary veins. So those of you who are doing pulmonary vein flow profiles, this is the vertical vein, that's something to be looking for if you're at all suspicious that the baby's blue and you're trying to come up with a good reason. This is another one. This baby obviously is on high frequency ventilation, was thought to have PPHN. The highest O2 was 55, and I'm not even sure that was real. And the baby was quite sick. Again, you got that left-right heart discrepancy, small left atrium, lots of right to left shunting. You'll see by color with bowing of the atrial septum. And again, the clue is that you should be seeing the pulmonary veins come back to the left side, the left atrium. And watch as we sweep up, you don't have that, right? So you have that back wall of the LA. There's really nothing coming into it. It's a small LA. The septum's bowing this way. And there's this pocket of stuff black back here. And those are actually the pulmonary veins and the confluence of the pulmonary veins. And you watch it and you can see something going up this way. And you'll see by color, I can actually make a diagnosis of supracardiac. Here are the pulmonary veins sitting back here. And as they course up, you see the flow going up towards the anomalous. This is a baby with supracardiac total anomalous pulmonary veins with obstruction. You got the whole diagnosis basically in the subcostal views. Also, when you go to that crab view, some of you are doing kind of crab view looking at the pulmonary veins. In fact, you can show the pulmonary veins, and if you're looking for pulmonary veins in a baby, look for the pulmonary arteries, because even in anomalous pulmonary veins, the pulmonary arteries come in, the pulmonary veins come right under the pulmonary arteries. So that's where you can look. But these are all the pulmonary veins joining a vertical vein heading north and joining the innominate. Another finding would be a lot of flow in the SVC in this baby that just doesn't make sense when you're doing your scan. So this is actually a vertical vein coming up. And again, there's obstruction, and this baby would require surgery early in life. Some of the ones that aren't obstructed still can have some pulmonary hypertension and will end up, those kiddies will end up going to surgery early as well. The other important thing is if you're managing these babies after surgery, recurrent obstruction of the total veins can occur in up to 15%. It's usually not great. Sometimes they can be repaired, not always. And that, of course, leads to pH, and pH is what guides. pH and symptoms are what guide us into when we go back in. You might see that in the neonatal ICU. Scimitar, pretty rare diagnosis, but something you may come across as well. Of course, with scimitar, you get the anomalous right, usually lower pulmonary vein, sometimes the middle pulmonary vein as well that goes to the IVC, rarely all pulmonary veins. And that's that scimitar vein coming down. And those veins will either join the IVC right atrial junction, or the actual hepatic veins themselves. The right lung is usually hypoplastic, and depending on how hypoplastic, that right pulmonary artery is going to be small. And then there's usually an aorta pulmonary collateral in keeping with kind of almost a sequestration, essentially, of that right lung, that hypoplastic right lung. It can be associated with other structural heart disease in up to 25%, and it's a whole spectrum of disease. But newborns are the ones that present typically with PH. That's usually how you see them. And the problem is that the presentation and outcome really depends on the severity of right lung hypoplasia, the presence of PH and how severe it is, and the infants, the neonates being some of the higher risk babies, and the presence of congenital heart disease. So those neonates are at higher risk of doing poorly, more so than kids who present later in infancy or later in childhood. So one of the clues, whatever the lungs are small on one side, the heart will shift to fill that space. And this is certainly true of scimitar. It's one of the features of it prenatally. You get mesocardia, dextrocardia, or dextroposition, where the whole heart can shift over into the right chest. So that's one of the first things. In the absence of a diaphragmatic hernia, be thinking small lung. And if you're thinking small lung, the pulmonary vein may not be normal. This might actually be scimitar. So that's classic. This baby obviously has a flattened ventricular septum. LV function's good, but you see a really flattened septum in keeping with pulmonary hypertension in a newborn. This is a little one that came from Saskatoon. What we're seeing is a much smaller RPA relative to the LPA, and you already start to think, this is probably my diagnosis. Sometimes you can have just an isolated right lung hypoplasia in the differential, but if you get the anomalous veins with or without that AP collateral, you're thinking scimitar. So usually you see the pulmonary veins come in nicely. This one doesn't come in normally. So the right lower is one of the easiest for those who scan to demonstrate flow in. Here is the left lower, left upper is the blue. There's a little right upper in this baby, and in fact, the right lower came down and joined the RA IVC junction here. So this is a baby with classic scimitar. So I think for anyone imaging these babies, but also looking after these babies, there is a risk in PREMS. And what we don't know is really the incidence and exactly why it occurs in PREM infants of evolving acquired pulmonary vein stenosis. And Angela has looked after a lot of these babies and may have some insight as to whether there's more data out there. But Linda Magoob and Ian Aditya and several centers in Canada and elsewhere put together their experience, and it's the largest experience worth looking at. They showed that it evolves in preterm infants born between 22 and 36 weeks of gestation. Most are diagnosed in infancy with a reported range between newborns within the first month up through 6 years, where there's documented lack of obstruction, that they evolve obstruction with time. Unilateral in the majority, 64%, and more often involving the left side of veins, almost 90%. Most present with late onset of pulmonary hypertension. And often the way they present is a kitty who's just starting to get tachypnic or just not behaving right. You go to do your echo, and the kid's got PH, and you have no explanation for it. It wasn't documented early, or you thought things were getting better. The freedom from death, this is important, or restenosis post-repair, is 73% at a year. 55% at 2, 5, and 10 years. And the key to this are the actual highest risk babies, which are those that have greater than or equal to 3 pulmonary veins that are involved, with a much worse outcome. Those with bilateral disease, and as I'd mentioned more often, it's left-sided disease, but if they have bilateral disease, much worse outcome. as you can see with these survival curves, and then SGA at birth, and finally an early diagnosis, including in the neonatal or early infancy period, which is when you may actually be seeing them. This is just a perfect example of a baby, or the one that we saw in our in the Royal Alex NICU, where you can clearly see there's pH. I mean, the RV's dilated, there's a flat septum, the LV's kind of pancaked a little bit there. There's a little ASD, so one of the questions is there an ASD? There was a little bit of bidirectional shunting, not a lot of right to left, but a little bit of bidirectional shunting in this X30-week, 3-month-old who was hanging out, getting ready for discharge, but starting to get tachypnic, and they were thinking infection. So this is what we saw. So this baby starts developing quite a bit of right heart dilation and dysfunction. There's a bit of TR that wasn't there previously, and this baby has suprasystemic RV systolic pressures. And so the first thing that we're going to do after that is look at the pulmonary veins, because it's a classic setup. So this is a left lower pulmonary vein. You can see not normal, and you want to make sure your Nyquist is set correctly. Your velocities are set. This is the left upper. The left upper is tiny and jetting, and the left lower is also not normal flow. You can see this continuous flow. Normally, it's a very phasic, low velocity flow in the pulmonary veins, but this is actually quite continuous in both. You had a mean gradient of 4 to 6 and a mean gradient of 5, where you measure that through the cardiac cycle. So this is a baby who has pulmonary vein stenosis, which could be progressive. And as I mentioned, unilateral is a little bit better than bilateral. So finally, getting on to our left heart obstructive lesions. There are several lesions that can contribute to increased left atrial pressure that then, of course, leads to high pulmonary venous pressure and high pulmonary artery pressures. Probably the worst of which is the hypoplastic left heart syndrome, which is not something that everyone deals with necessarily, but other critical left heart lesions can do this as well, especially critical AS with poor function. If there's a restrictive atrial septum, they can be actually very sick and quite blue. Or a restrictive atrial septum or intact septum rarely occurs. Coarctation of the aorta is another that you can sometimes see. Left atrial hypertension, critical aortic stenosis, severe mitral stenosis or regurgitation. Core triatriatum, they're rare in newborns, but occasionally I didn't even have a case to show you, but they're occasionally present, and I just looked at a report recently of even a fetal core, but that's very unusual. They're usually later in infancy and progressive. And then primary LV myocardial pathology, we'll talk about that a little bit, especially who's at risk. And then the weird and wonderfuls, which I'm not going to go into, there are cardiac tumors, aneurysms, coronary arteries, cardiac artery anomalies, usually not presenting as neonates, occasionally as more often as young infants, that may lead to high LA pressure that progresses to pulmonary hypertension. So just to show you a few examples, this is a hypoplast with quite a small left ventricle, and you're seeing very high flow velocities across the atrial septum. This one's not as bad as some of the ones that we've seen, where they're almost intact. It's a 2-hour-old newborn who presents with severe cyanosis, pulmonary edema, and pulmonary hypertension, requiring, in fact, an urgent or relatively urgent septoplasty. One of the things I would always ask our fellows, because sometimes we do get high gradients, is what are the oxygen saturations? If the oxygen saturations are high, those gradients are flow related. If the oxygen saturations are quite low, in fact, the LA pressure must be high, and the baby doesn't have sufficient pulmonary blood flow as a consequence, and will be developing pulmonary edema and pulmonary hypertension, of course. So this is a mean. We usually measure our atrial level communications with a mean gradient that tells you the difference in the mean LA and RA pressures. So that's actually the most useful. That's what we would use to clarify or qualify significant obstruction. And this baby had a mean gradient of about 12. And that number of 12, that mean gradient of 12, means that the LA pressure is 12 points higher than the RA pressure, and that's not going to be normal. Normally, it may be a few points max, and if it's a bigger hole, it may not be very much. But measures that are in the 10 on up are definitely not normal. In a lot of normal hypoplasts that have a little bit of restrictive septum, their mean gradients are more like 5, 6, 7, and that can be fine. One of the things to note, as I loved looking at pulmonary veins, and as you guys are those who are doing TN echo These are sort of things to be thinking about. Normal pulmonary vein flow profiles in a hypoplast have a peak in systole, an early diastole is good forward flow, and then a little flip, a little whiff of a wave reversal, which is not always seen after birth in normal babies. What happens as you get higher and higher pressures of the LA downstream is you lose the early flow in diastole in the pulmonary vein, and you get increasing A wave reversal and S wave. So you get this to and fro flow profile with no real egress or not enough egress out of the LA. And this is going to be obviously very bad and can lead to muscularization and issues with the pulmonary veins and the pulmonary vascular bed in general. So this is not a good thing. They often, this is something that presents in utero and probably already sets them up for high risk of issues around their pulmonary vascular bed in the long run, as suggested by papers that have looked at the clinical outcome of these babies. Critical cohort, I put this one next because it really is a more common scenario for many neonatal units. It's one of the more common lesions that we see. It tends to come around all year round, and it can happen in all sorts of situations. But the key here is, and we pick up about 60% of them prenatally, fortunately, but even when we pick them up, it doesn't mean that we are necessarily going to keep them on prostaglandins. So whether or not they're ones that are picked up prenatally, the question is what happens with ductal constriction. So when we're trying to decide whether the baby has coarctation or they present to you as there's ductal constriction, that results in increased LV afterload. That leads to increasing left ventricular and diastolic pressure. It also leads to LV systolic function that's decreased. And that will also, as the ejection fraction gets reduced, lead to higher and higher volumes that are left and end diastolic pressure. And we'll talk about other lesions that are important in coarctation as well. So some coarctations are not just simple isolated corks. So that alone, those increased LV and diastolic pressure will lead to increased LA pressure. But also mitral valve stenosis is very common in coarctation, small mitral valve as well, aortic stenosis with LV outflow tract obstruction, and both of those are going to ultimately lead to increased LA pressures. Ventricular septal defect, so you get ductal constriction, you increase the afterload of the LV and the pressure of the LV, and you're going to drive more flow through the ventricular septal defect and increase the pulmonary blood flow, increase your pulmonary venous return, and guess what that does? You're going to drive up your filling pressures. You're going to drive up the LA pressure even more and make the kiddies sick. And then finally, associated left ventricular hyperplasia sometimes is there in the borderline left heart with coarctation of the aorta. And for those, some of those will have increased LV and diastolic pressure. So that's important. So this is just an example of a baby who presented postnatally at 2 weeks. Tachypnic with tachycardia and low output. And this might be a baby who gets admitted to your units or where you see them on the unit. And you can see this baby clearly has a high RV pressure with flattened ventricular septum, a little bit of a smallish abnormal looking mitral valve, and both ventricles aren't squeezing super well. So this baby has reduced RV and LV function. Evidence not seen well here of left atrial hypertension, but we'll get a better sense of that. And that's ultimately going to lead to pulmonary hypertension. So this is a baby who will likely develop tricuspid insufficiency. And this baby, in fact, has suprasystemic RV systolic pressures. So when you're measuring blood pressure, say, in the lower body, these are way too high for a newborn. So this is why that right heart's not happy. The tricuspid valve's not happy. There's even pulmonary insufficiency, all in keeping with a baby who's evolving pH, secondary to the duct starting to constrict. When the ductus is open, and we'll talk about that actually in a few seconds. So this is a baby who has, in fact, a coarctation. You get the kind of elongated appearance of the transverse arch that's hypoplastic. The transverse arch should be twice the size of the carotid. When the transverse arch is the same size or only slightly bigger or smaller, it ain't normal for that baby. And so that's a good rule of thumb. And then you're seeing turbulent flow at the distal end of that arch. That abdominal aortic Doppler is very blunted, slow systolic upstroke, and then continuous flow in diastole. This is a classic picture of a neonatal coarct. And then you get a gradient through the distal arch by CW Doppler, again, in keeping with coarctation. And in the presence of biventricular dysfunction, that peak of 40 doesn't sound like very much. It's too much for that heart. So what happens when you start your Prostans or when the baby's got now an open duct? I think it can provide a pop-off for the right ventricle so they don't get sick that way. You saw that that baby had suprasystemic RV pressures and that function was not very good and it was compressed in the LV. But also in reducing arch obstruction, it can help improve the left ventricular function and reduce, as a consequence, LA pressure. Now, if you have a baby who's had surgery for a coarct, you want to make sure that the baby's coarct is repaired because sometimes it's not perfect or there's ductal tissue that results in evolving obstruction again. But you also want to rule out additional left heart obstruction. So if that baby still has pulmonary hypertension, you need to make sure that there aren't other issues going on. So rule out additional left heart obstruction, rule out primary LV myocardial disease, rule out other cardiac pathology. And Angela's going to be surprised, I think, that I'm presenting this little one. This is a little one that was quite a challenge that she's dealt with relatively recently. A little one who had had a coarct and TA-PVC repair, in fact, as a newborn, where the repair went well, and she was out quite quickly. She was admitted to a local hospital, though, about a week and a half or so after discharge from our hospital with tachypnea, poor feeding, and poor perfusion. And there was new onset of atrial ectopy. You can see this. So this baby had these repairs. The initial echo suggested she had some element of pulmonary hypertension. That velocity is 3.2 meters per second for a mild amount of tricuspid insufficiency shown here. Minimal, right? It's just a whiff of pH. And you can see that the septal there is a mild amount of septal flattening. So this baby has pulmonary hypertension, but it's not terrible. And so, but with this finding and with poor perfusion and her just not looking bright, they started nitric oxide and actually intubated or ventilated her and started some NO, also giving her some inotropes. They couldn't come up with anything that was suggestive that she might have an infection, although there had been some question about a wound infection. Everything was negative. She hadn't had any ill exposures. But on nitric, the following morning, this is what her heart looked like. And one would have thought she would have just gotten better. What there was at least moderate TR, maybe even severe. The RV systolic pressure was now 5 meters per second, suprasystemic, and she had new onset pulmonary insufficiency. And you can see that that LV looks compressed by quite a hypertensive RV. And you say, what the heck happened? She looked far worse despite being on something that should have helped her pH. And we immediately said, she's not tolerating the pH. Maybe we're missing something on the left side. Stop the NO. Chest X-ray showed just florid pulmonary edema. And I forgot to show this, but it had gotten even worse overnight. It just went from mild pulmonary edema to just profound pulmonary edema. And we said, this is like a kid who's behaving like there's still residual left heart obstruction or pulmonary vein obstruction, and yet the echo didn't see it. The left heart looked absolutely pristine, including the arch. That left heart function looked good. So she was actually, we had her go off to have a CT scan. And in the course of having her CT scan, she got a little bit sick. She came back and they said, well, you know, let's restart the NO. We're not happy with her. She must be having something that's progressive. So the NO was started. And several hours later, this kid just fell apart. And with that, she was immediately transported to our center. And we stopped NO, helped support her in other ways, but got her off NO. And within like 24, 48 hours, this was her heart, was back to normal. And you say, what? We did a CT. The CT showed no left heart obstruction, no pulmonary vein obstruction proximally. But the response to NO, which happened twice, was useful in confirming this diagnosis of pulmonary vascular obstructive disease. Her CT scan was nonspecific. It doesn't really completely make that diagnosis. This response to NO in the absence of anything else going in the left heart is the diagnosis. It's a rare disease, hard to find a lot of data on in the literature. It can be associated with congenital heart disease, but also can be seen in isolation, and they can present at different times. They're not all as infants or quite young. It's confirmed with worsening pressures in response to NO, and it's a terrible 2-year, like a very, very, very poor survival if you've presented a less than 2-year. It's a less than 2-year survival after this diagnosis has been made. So we were just really amazed how different the heart looked off NO, but a very, very sad situation for this little baby who was being worked up for a lung transplant. So finally, two other diagnoses. Critical aortic stenosis is associated with LA hypertension, in part due to high end diastolic pressure. with high afterload because of the obstruction, but also a lot of our critical ASs that evolve prenatally have some element of endocardial fibrosis that can be diffuse or patchy that will lead to the ventricle being quite stiff or non-compliant. Well, we use the term as restrictive physiology. The mitral valve may also not be normal. That may be hypoplastic. It may be stenotic, often with matted chordae and papillary muscles that are echogenic, or it may have regurgitation for the same reason. Balloon valvuloplasty may not completely resolve the issues as a consequence of underlying small aortic outflow, which is one of the problems with these babies. Also, the presence of aortic insufficiency. If there's a lot and you have a stiff LV, it's not going to be well tolerated, or if there's persistent mitral valve disease. And just as a couple examples, this is a baby that we actually delivered in the Mazankowski OR because the baby had some high drops. The LV was thick, poorly functioning. We thought there was AS. We'll go back there. You can see a very dilated LA, and there was really not anything significant in the way of an atrial level communication. So the baby presented cyanotic at delivery and tachypnic and evolving pulmonary edema. So he immediately had an aortic valve dilation. But hypertensive LA, very bowing atrial septum into the RA, minimal MR in this baby, which is important because of what happened, and the very hypertrophic, thick-walled, bright, you can see the echogenic endocardium here. This is a baby with critical AS who has high LA pressures based on that dilation and bowing of the atrial septum. Without the atrial septal defect, I can't tell you what the LA pressure is. And we're looking here. This is the baby after the dilation, but the LV function initially was still quite poor. What you're seeing is all this echogenicity of the endocardium. That's all patchy areas of fibrosis. And also it can involve the mitral valve in these babies, and that's going to contribute to high filling pressures. This is this baby after the dilation. We were really happy. The function was getting better. Baby, we were able to close the duct. We were super happy, but this baby still had pulmonary edema, still had a big LA, severe pulmonary hypertension. In fact, this baby, after that dilation, we were now measuring a mean gradient through the mitral valve of 18. That is what we usually use, that mean where you're actually planaring the whole VTI inflow Doppler. The mean gradient is equal to the LAA wave minus the LVEDP, which is your gradient, or that's the difference, or the what obstruction is measured in the cath lab. So that's a mean gradient through the mitral valve of 18. It shouldn't be more than 3. So that just tells you this baby had severe MS that changed his course. This is just another case that was another example of critical AS with a very dilated, dysfunctional LV, a little bit of echogenicity, and severe MR. So this is a little bit different, but from a lot of the same mechanism, that mitral valve gets secondarily affected with fibrosis and can be quite small, or can have very bad coaptation, or can become stenotic. And this baby, after valvuloplasty, had persistent severe pulmonary hypertension and pulmonary edema. That was at least in part due to the severe regurgitant mitral valve. The other element to think about, and I'll show you in the next slide, this is the atrial septal defect. As I said, the mean gradient that you measure across the atrial septal defect, you can see the MR here in this baby. That mean gradient was 16, in keeping with an LA pressure that was 16 plus the RA pressure. Very, very high, and something that's not going to be very well tolerated by anyone, let alone a newborn. And this baby had bidirectional flow across the duct, in keeping with, again, high pulmonary pressures on a baby who's going to be very difficult to manage. Just to put it out there, I love restrictive physiology. I hate restrictive physiology. I hate it because it's really tough to treat, but you need to be thinking about it for those who do manage some of these babies in the NICU. So these babies who have these fibrotic-looking left ventricles, it's also important myocardial disease. That's primary myocardial disease. A normal pressure volume curve sort of looks like this. So with increasing volume, you get a little bit of increasing pressure. But if you have a restrictive physiology, if you have a very stiff ventricle, that pressure volume curve changes. So for the same amount of volume, the pressure of that LA, or the end diastolic pressure, is going to be higher. And so these babies sit at very high pressures. And now you're going to add a little aortic insufficiency because you've just dilated the aortic valve, and you have a kid who's got mitral insufficiency, and that ball game may be tough to manage. Well, ball game may be over. So that increasing preload doesn't help these babies. It substantially increases their end diastolic pressure and their LA pressure, and they maintain high pH, and you can't really treat them, as Angela, very easily, as Angela will attest. Finally, this is just one other example. So some of the babies with primary myocardial disease, not super common, we get about 3 or 4 a year, can also have it. This baby had severe systolic dysfunction, but it also had a lot of endocardial fibroelastosis, also some fibrotic appearance, both of the mitral valve and the endocardium. And this baby was quite tachypnic, had pulmonary hypertension, but had severe dysfunction, had pulmonary edema with low cardiac output, a dilated akinetic LV with fibrosis, no aortic stenosis though, and the LA, which I'm not showing super well, was really quite big, and the atrial septum bowing into the right atrium in keeping with high LA pressure as the reason for pH. There was bidirectional flow in this baby's duct. The right ventricular pressure, in fact, was fairly high. I can't remember, this one was at least systemic to suprasystemic, because it was 71, which the blood pressure was 71. So it's 71 plus the RE pressure, which in this baby may have been 10 or 15, 10 points or something like that. So it was suprasystemic. One thing that we saw was this bidirectional duct, suprasystemic RV pressure by TR. The mitral valve inflow had a very short pressure half time in keeping with high filling pressures and low A wave velocity, all of which are in keeping with kind of a restrictive picture, but you can't really fully rely on these. And the LA pressure, in fact, when we took the kitty to the cath lab and balloon occluded the ASD, was 40. So this is a baby who's not going to do well and who's going to have really tough pH in the setting of very high LA pressure. Might be a baby that we would consider if we really don't have much option putting in a bad and buying some time for our heart. So in conclusion, or in summary, TAPVC with obstruction is associated with right heart dilation, a small LA, an underfilled LV, and right to left atrial and ductal flow with that reverse differential of high SATs in the lower body. A confluence of the pulmonary veins and the vertical vein can be easily seen coursing behind the left atrium in those subcostal sweeps. So those who are doing TN echo in these kids, it's an easy view to be looking to see if you see pulmonary veins coming in. TAPVC with obstruction largely occurs at the vertical vein to the systemic vein connection, but may also be secondary to an anatomical vice. Often the bronchi may involve the arch on that side, especially for those supradiaphragmatic or supracardiac TAPVC. Scimitar is associated with an anomalous right lower pulmonary vein, right small lung, RPA also being hypoplastic, an AP collateral in the presence of significant pulmonary hypertension and congenital heart disease, which are often seen in the newborns that have this condition diagnosed, increase substantially the risk of a worse outcome. Pulmonary vein stenosis that is acquired can be found in preterm neonates, associated most often with later evolution of pulmonary hypertension, a dilated RV and tricuspid insufficiency, and eventual compression of the left ventricle. Left pulmonary veins are most often affected. The prognosis is worse for those with early onset, less than 6 months. So in your camp, where you may see some of these babies, as well as bilateral pulmonary vein disease, involvement of more or equal to 3 pulmonary veins, and being born SGA. And finally, neonatal pulmonary hypertension could certainly be secondary to left heart pathology with left atrial hypertension. Left atrial dilation with an atrial septum that bows tensely into the RA is one of the clues to that. Even if the left ventricle is not very big, I didn't show you a case where you can have restrictive physiology and a very dynamically functioning heart, but have very abnormal diastolic function, and you get that same picture of a big left atrium and bowing of the atrial septum and a more normal sized left ventricle. ASD flow can be used to calculate the mean gradient to determine how high the left atrial pressure is. We will often confirm that, or may confirm that in the cath lab, especially when we're trying to make decisions. And then finally, a severe LV myocardial disease with high filling pressures with or without systolic dysfunction certainly may be associated with newborn pH. So thank you very much for your time, and I think that we'll take some questions.
Thank you very much, Dr. Hornberger, for that very thorough and informative, engaging presentation. It reminds us of the very vast differential diagnoses of patients, especially neonates who present with hypoxia or what we clinically call pulmonary hypertension. So I think most of us on the call deal more with the preterm babies. So one of the questions that I wanted to ask was, what is your current practice with regards to surveillance of echo surveillance of babies born preterm for pulmonary hypertension, chronic pulmonary hypertension, and other comorbidities?
So I know that Angela is more involved with the management of those kids. Our TN Echo service usually does those assessments, especially for the very preterm babies. We'll look at them quite early, and often we'll have maybe a study every couple of weeks, something like that, or every 3 weeks, something like that. Usually at some point, the cardiologist also will perform an echo to confirm normal anatomy and that we're not missing something. And if the baby's not behaving right, or if there's any question, we've had, and part of the reason I threw in the pulmonary vein disease and the TMPVC is we have had a couple TMPVCs diagnosed by our T and echo folks, or suspected by our colleagues over the past few months. And I think it's an important diagnosis to keep in the back of your mind when kids present sick. So they do surveillance, much more so than we did previously. Unfortunately, Abbas Haidari is spearheading that on the neonatal side. He was on service and unable to attend today. I did ask him to participate, but and then we usually get involved where there's concern to confirm from an echo perspective, and then Angela's team, the PH service, then is usually called in if the babies have PH to be involved with their management. So much more aggressive than we were even 5 to 10 years ago.
Okay, thank you very much. So, Dr. Bates, you're involved with the treatment and management of these patients. What are the kind of first line therapies that you tend to move towards, and what kind of criteria do you use for those different kinds of treatments? That's a very broad and open question.
No, thank you so much. And thanks again for having me participate. Sorry for the background noise. Let me know if you can't hear me well, but no, as Lisa knows, we're often consulted, as she mentioned, a little bit later once there's a bit more severe signs of pulmonary hypertension on echo. But one of the things, one of our biggest approaches to pulmonary hypertension, any of the neonatal babes, is we sort of break it down into, what's the etiology. So when you look at your group classifications of pulmonary hypertension, is this more of a true pulmonary arterial hypertension, which in and of itself is pretty rare to present in neonatal age group, but not impossible. And then we, of course, go down the road of left-sided heart disease, which is what this talk is about. And then we talk about the developmental lung, which you can have mixed, which always makes it a bit complicated. So if there's any sign of structural left-sided heart disease, we address the issue first before adding on any type of pulmonary vasodilator. And one of the simple first-line therapies is just even adding in some diuretics. But then we're often getting an idea of, is this significant pulmonary vein a stenosis? Do we need more information, including a CTA of the veins, a perfusion scan to kind of look at the functional effects on the patient, and then of course progressing towards, is there actually something surgical and or cath-based that we need to intervene on? So I would say our first line therapy would be considering some diuretics to get the lungs a bit drier, because that often helps your pulmonary pressures. And then if you're looking at left side heart disease, is there some sort of management? And if it's not something surgical, even something, in terms of the cardiomyopathy type patients, is there an indication for a VAD, that sort of thing. So now if we've addressed the left side heart disease, if this is a patient that's post pulmonary vein stenosis repair or post TAPVD, then it's not uncommon to sort of start to balance in the benefits and risks of a pulmonary vasodilator. And our first line agent is still PDE5 inhibitor. We typically start with sildenafil at our center, we do have access to liquid formulations of tadalafil, so we will often flip to a once daily preparation if the patient's stable. It's not that uncommon now that around, especially North America, where we're starting to see more and more of these babies do well post-op, but have some residual pulmonary hypertension where they may even get added on a second agent. But you really have to make sure that there's not still a primary problem that needs to be addressed surgically, especially in the post-op vein repairs, for example, or the significant left-side heart disease like the mitral stenosis, coarctations, etc.
I was thinking the other thing that we often get, we work together on, is there are a number of babies that will have an ASD or a VSD, and those are ones that are tough because they often have high PA pressures, even with an ASD that a normal kid wouldn't have, but that amount of flow, whatever it is, along with, you know, as a consequence, perhaps with the underlying lung disease that the prems have, it's not unusual to have some elevation in PA pressures. And that's where we go through this whole, you know, do you treat or are they going to get sicker? You know, and where's the balance there? When do you intervene on an ASD that we would normally not want to be intervening? And how do you intervene as least invasively as you can when the kid's as big as they can be? You know, so there's a lot of that discussion that we do between teams in trying to do better with these kids. We're doing more duct closures as well, I think, with the smaller and smaller babies, and being more aggressive about that to try to optimize their circulation and their pulmonary health. And Angela is often really very much involved with all of those kiddies. I think that the ASDs, this is something that we've had a lot of conversations on. ASDs themselves, I think that, you know, with all of the work that has been shown over the years, and I think Amish, you've been a part of this, and others have, that, you know, prems have some element of LV dysfunction, especially diastolic pathology. There's no question. There's data in the animal literature. There's data we've published. There's data now. We have tons of data now in teens that they continue to have diastolic pathology that looks like aged hearts. And I think with that, they may actually shunt more than the normal kid, because you got a high-end diastolic, it's going to drive flow through the hole. That may add to a shunt being much bigger than you expect with an ASD that we normally don't see. So those are other things that we often will think about and talk about.
Yeah. And I would also add to that, sorry, I would also add to what Lisa said, is that the other component of that is just what makes that patient more susceptible to having a reactive vascular bed. So if they are a prem, if they are syndromic, for example, those are definitely things that set them up to be a little bit more susceptible to the increasing shunt flow in those ASDs, or the back pressure, like from the post-capillary abnormality you might have in left-side heart disease. So I always find that really amazing. And we've actually been moving to doing with the shunts to trying to be less invasive. So we use a lot of echo at our center, and T&E is often the first place that things get picked up, as Lisa was mentioning, but moving more towards QPQSs in MRIs. So you don't get the resistance, but it still gives you some information to kind of drive decision making.
That's a very, very interesting discussion. And Lisa, you presented some great collection of cases. I don't know how many years it took to collect these. I feel a little bit reassured by the practices to some extent, because we tend to come across the same issues. And it's a very interesting point that the LV diastolic, inherent diastology might be driving some of these ASD shunts. To be honest, I didn't think about that per se. I was more thinking in terms of pulmonary vascular hypoplasia or a reduced pulmonary vascular bed in general in prems, particularly with BPDs, and perhaps why they become symptomatic with the smaller ASDs much sooner than what you would. It took me many years to convince our cardiologists to be even interested in ASDs of these kids, because they look at the size and say, there's no way this kid can be symptomatic. And we tend to use diuretic also as first line for both pulmonary PH as well as ASDs. Number one, it tends to take away the pressure of deciding ASD versus PH, because both treatment are the same. So even if we don't have to debate that pulmonary vasodilator business in our head, so only when diuretics don't work or kids continue to get symptomatic, that's when we struggle with the same question, and we end up discussing with the cardiologist what to do. Our experience has been very good with diuretics and pH. The pH pressures tend to come down after they have diuresis a little bit, and oftentimes resolve over the next few months. So we tend to use a lot more of that. I'm intrigued, and I actually want to know your thoughts about it. Up until 3 years ago, I thought I'll never see a pulmonary vein stenosis, because we have been doing the screening in our unit for like 6 years, and I just never come across one until 3 years ago. We had the first kid with quite severe diffuse pulmonary vein stenosis presenting as PH at 36, 37 weeks. And the cardiologist said that this is not repairable, and basically was expected management. And as it turns out, it just outgrew. They just got better on their own. And over the next first year of life, everything went away. So I was quite intrigued by that. I wonder, do you see pulmonary vein stenosis in the context of BPD kids occurring in hospital, or is it a phenomena which occurs afterwards, post-discharge? Because we right now don't follow all the BPD kids after discharge. So I don't know, you have any thoughts about that? What is the typical time period that pulmonary vein presents?
I mean, I've seen over the years, most of the ones I've seen have been in the hospital while they're still in the NICU.
Right.
And Angela has maybe a little bit different experience, but that's sort of, and I actually picked up a bunch and I sent them all to Ian because I was like, I don't want to take care of them. Pulmonary vein stenosis is like one of the worst things. If it's going to progress, you don't want to be a cardiologist taking care of them, unfortunately. But that's what I've seen. But looking at the data that Ian had published with Linda Magoob, they were seeing kids all the way up through 6 years. And it was a part of, I think, a group that he was still following of PREMS as well, because he did some outpatient surveillance of those kids. But Angela, what about you?
Yeah, no, I would have to agree with you, Lisa. I would say the majority get picked up mostly because we are so diligent because of the experience between that Ian and Linda had shared. And so most of it's being picked up early, but we do occasionally get a few PREMs that have been sent home and then come back to respirology clinic for either follow-up or just need extra oxygen requirements. And then we get referred a consult. And then they may have some mild elevated pulmonary pressures. One of the first things we do is if we can't see all the veins really well on echo, is getting a CTA, which can help kind of clarify that. So we've had a few later presentations. Now, was it that we just didn't get good enough views earlier on because the patient was doing well and we didn't do a really hard look? Often you look back and they go, oh, we didn't see the right upper pulmonary vein, or we didn't see, you know what I mean? So I think there's a few that may have been just missed earlier on because clinically they actually did quite well, and I wouldn't have pushed for vein views at, for all 4 veins at that point in time either. But most of our center, we are picking up quite early because we're more diligent, I think, than we used to be.
And we do the same. We kind of watch them, right? Unless they have BH or bad symptoms, you don't jump in yet. You want to see how they're going to progress. And then as they get more symptomatic, we've tended to then jump in with the idea that some of them may get better, especially those that aren't bilateral disease. But then we've had some have pretty bad outcomes. So we've seen both ends of that. The other thing I was going to ask you guys, so this is off a slightly different topic, but I know that Angela and Sue Richards, her NP, are very involved. And I've seen a few times where on our nursery, people have missed the fact that kids are aspirating. And aspiration is a big thing in our cardiac kids, but I think also can occur, and certainly something to keep up there if you have a kid with PH. And you have the lung disease, but maybe they're aspirating, that's contributing further to it, and making sure aspiration isn't part of it, because you're obviously going to treat that a bit differently. And we've had success where you've gone through that pathway and the kids have gotten better just dealing with the aspiration.
Yeah, no, sorry, Angela, go on.
Oh, no, I was just going to say that's actually something too that came up a little bit at the International UCSF Neonatal and Pediatric Pulmonary Vascular Disease Conference this year. Was just more about the contribution of aspiration even to PVS progression. So we know that, neck especially and other infections can cause progression of pulmonary vein stenosis, but we're learning more and more that probably the inflammation that occurs with aspiration can drive that as well. So just something that I've been a little more attuned to watching for as well.
No, I do think that there is something important there that we just don't know how best to diagnose. Because if you look at chest X-ray of these kids with BPD, they all look the same, all have inflammation, and it's something which underappreciated and probably missed. I mean, what I tend to do in our practice sometimes in the kids who have got bad lung disease at that age and seeming PH and we can't really rule out, I tend to give them a trial of an NJ feeding for a couple of weeks. So, I wouldn't have the numbers on top of my head, but there have been cases where just by NJ feed, but 7-10 days, they're a completely different child. But there also have been cases where nothing changed. And I still can't decide who do I give it to and who do I don't. So I just end up trying. It at least seems like a low-hanging fruit.
Yeah, I will say, Amish, one thing we've had experience with, and I know that Steve Admin out of Colorado does a lot of PH and is a pulmonologist. One of the things that we've found is that we have quite a few patients that have severe pulmonary hypertension. Either they've got BPD or PVS, but something where their tone is a little bit different. And we find that NJ feeds don't always do the trick. I think because there's an element of reflux, and you now have still stented open the esophagus. And so, and I think because they have short esophagus and then they're working, so they bear down, it's sort of a cycle that happens. And so on occasion, a few kids, even that aren't even ventilator dependent, but just have severe, we have one kiddo that's had severe progressive PVS in his next 22-weeker, and his lung disease isn't that bad, but it was worsened by the fact that he was refluxing. And until we did a G2 fundo, we didn't really see the full effect. So just something to think about. I'm not advocating for G2 fundos in all of our kids, but just in those really tricky kids, especially those kids with pulmonary vein stenosis where you don't have a lot of great options. And we've also moved towards when surgical and cath interventions are really limited, there's been a little bit more exploration in medical adjuncts for the pulmonary vein stenosis kids. So Gleevec being one of them. Again, literature still evolving. And then recently sirolimus was produced. I think there's a paper in 2021 by Patel out of Atlanta, and they had a lot of prems. Now, the risk, of course, is then opportunistic infection. So I don't think it's without risk, but just something that you guys might see a little bit more, the thought, different options of approaches to some of these kids. And it's usually a multimodal approach. And so we've been doing that a little bit more at our center, especially those kids that are really high risk and have had sort of a malignant kind of pulmonary vein stenosis substrate.
Yeah, no, that's true.
I have one question for Amish and Lisa and Angela. Like, we normally as TNE people are screening babies at 44 to 36 weeks, right? And we normally are dealing with pulmonary vein pressures, and we look for chronic pulmonary hypertension. But we've seen a lot of times it's a big ASD, or it's diastolic dysfunction, or the famous pulmonary vein stenosis that I've also been searching for. But shall we be screening these babies later? Because a lot of the times these babies go to the pulmonary hypertension clinic, or in our case, they continue and follow up with us and independently with cardiology. But shall we screen these babies later on? And if we want to sell a pulmonary hypertension clinic to our hospital, how often would we be picking new things that can help us giving them better treatment?
Oh, great question. Angela, I'll leave that for you.
Yeah, no, that's
my
a
clinics
really,
are
really
already
good
backlogged.
No, that's a really good question. So Abbas Hadari and I have sort of embarked on trying to do a screening protocol for especially just even BPD kids, just starting there. And we found that really, like, because they're doing TNE, so that part of it, the mild pH kids that they're picking up, the babes, they can intervene on, which is sort of non-pharmacological interventions. Often it's more better respiratory support, affecting the adjusting aspiration, upper airway issues, etc. And so we've really just left it trying to target the moderate and severe pH, which again, you can argue what that definition is, but anything that's sort of, closer to systemic pressures, any RV dysfunction, etc. Or really needing significant respiratory support and not really having another good reason why, except for their pH. And so those kids, I still am not sure yet what the numbers are going to be and how many of them truly need to be followed through an actual dedicated pH BPD clinic. So I can't answer that yet for you. And I know, one of my experience at CHOP was they had sort of a link clinic of those really extreme prems that are high risk. They were already being followed through by a pulmonologist, and then pH would link on. And they, again, they were seeing higher numbers, but that was a really large clinic. So I think hopefully within the next year, we'll have a bit more better answer for you as to, how many patients would really need to be screened a bit more thoroughly post. I think if you have right now a really good follow-up plan, either with a really good pediatrician and or a really good, ex-prem BPD clinic, I think there you can actually catch a lot of patients that just aren't following that natural progression of improvement, and they can be flagged to be seen either by your local cardiology team that sees PH kids or your PH service if you have one at your hospital.
We also echo the kids if they haven't had a proper echo, TN versus pediatric cardiology.
Yeah, got it.
I'm involved in both sides, and I've helped our TN guys doing a lot of echoes across the country.
You will soon have a bunch of comments coming your way.
Yeah, no, we're very much. It's actually helped our service as well because we were just getting inundated. But we often will do a full echo on the kids before going home if they have ASDs or an ASD of greater than at least 3 millimeters or 4 millimeters, or a couple of ASDs. With or without a duct, we actually bring them back. So they all get seen, and depending on the size of the ASD, depending on what else we're seeing, if there's any PH, obviously we move them forward to be seen by our colleagues in the PH service with Angela, who's in charge. But so we are screening them, at least from a structural standpoint and an ASD standpoint. And we have now a few hundred that we're reviewing. We've been doing this for a number of years. That we're reviewing for how many of them close spontaneously. Do they close the same way as a term baby? Because we have data on that. And where could our cutoffs be as to who you're going to see,
right,
and when? And so that we're working through that this summer with a student, finishing off a project we started last summer.
That would be very informative.
So with TN Echo, you guys are seeing them. So as you're seeing them, and then they're referred on, what do we do with them? I mean, are we creating more work than we need to, or is it actually a group of patients that we really need to be following? Like,
so I think, Daniel, to your question, it also depends upon the workload management afterwards, especially in public health setups where your clinic can get filled up very quickly, and people are not interested in just filling up their clinics with patients who don't need. You really have to justify it. We have tried to do come up with some sort of guideline in Toronto, and unlike you guys who are such a good cardiologists, our cardiologists just couldn't agree. we discussed.
You're not really in the same building.
That's true.
I'm in the same building with them. They come find me.
So we discussed this establishing a PhD clinic, and with both Theo in Toronto and with when Tillman was here. But again, just the sheer volume was impossible for them to accommodate. So what we tend to do now here is basically we screen them at 34 to 36 weeks as we normally do. If they remain on respiratory support during inpatient, we continue screening them every 3 to 4 weeks. Sooner, if there is a worsening, if there's no worsening, then every 3 to 4 weeks they get a surveillance till they come off respiratory support or they go home on home oxygen. If they're going on home oxygen, then those are the patients that they really focus on following up in sick kids with cardiology and respirology. But if they're off respiratory support, and if we have to manage their pH, which is by diuretics and sending them home on diuretics, then we follow them up with cardiology. But ASDs, we don't, because sick kids basically told us that the ASDs could be followed by community cardiologists. So we end up using them for that purpose, again, for the clinic business. I don't know whether we're doing absolutely optimum, but at least we are trying to find, as Angela was saying, the moderate to severe cases where things are either stuck or not progressing as expected is where we really try to hone in on follow-up.
Yeah, and I would say, Amish, we're actually doing kind of the same. Well, that's what our protocol that we've been proposing. It kind of got layawayed by COVID, but it's very similar to what you guys are doing in Toronto. So hopefully there'll be a little bit of consistency across the country. And hopefully, like you said, we'll have a little bit more information in the future as to how best to follow these kids. I think the other big thing is we just have that many more of these really severe patients that do really well. You know, when you have an X22 weeker that's doing really well and maybe has mild BVD, that's incredible. But that means how many more kids do you have that are surviving, but maybe have that risk of severe PH? And do they have, and I think what we learned too is their vascular bed is not quite normal, but did they have that insult to sort of bring PH out? And not all of them do, some of them do. And I think that's also a little bit evolving as to how to really predict which patients are going to get into trouble.
And sorting out the pathogenic mechanism, why some do and some don't with the same condition, like you know.
Yeah. One more thing, Angela, you mentioned that they use MRIs for doing QPQS and phase contrast MRIs. I'm assuming that. I'm just sort of sharing our experience recently. So we recently finished a small study, only 17 patients, where we sort of did an echo and MRI on the same day. So these are patients with chronic PH and BPD at 36, 37 weeks. We just presented that in conference, and the onus is on me to write the paper this year. And we basically try to evaluate QPQS. So QPQS was measured by phase contrast, and we examined our echo ability to do QPQS and does it correlate. And we try to use slightly different calculations. So where do you measure the pulmonary valve sort of diameter to calculate the right ventricular output to be able to, and whether it is VTI versus VTI, whether it's stroke volume versus it is whole minute cardiac output versus cardiac output. And we actually found that the QPQS and echo, and they both were analyzed by different people. So Mike Seed did the MRIs for us, and then one of his fellows analyzed the echoes, the MRIs, and our research sonographer analyzed the echoes. They correlate beautifully. We had an R value of 0.83 for the QPQS on MRI versus echo. And the best correlation was found when we use stroke volume, not so much VTI, and also not the whole minute cardiac output. So if you just use stroke volume of the right and left, that correlated very nicely with the QPQS calculated on MRI. So because we can't do that many MRIs, we don't really have MRI in the unit, they're in sick kids, and each time you do an MRI, it's a big cumbersome thing. So we tend to use that QPQS ratio, as Zachary was saying, as sequential rather than one-off for diagnosis. So we tend to use a lot more in echo now when we are doing our ASD assessment, or try to understand whether pH is coming from the large ASD shunt purely, or a combination. And the other thing we tend to use a lot more in these kids is a BNP as a sequential value. And I don't know what your experience with that is. I seem to work quite nicely to tell us disease progression, not one-off, but sequentially. I don't know whether I am biased by looking at them, or do you guys have a similar experience?
NT-proBNP, what are you measuring?
We're doing NT-BNP, so for NT-proBNP.
Okay.
Yeah, we use a similar, it's part of just another tool that we use to kind of follow. It helps to reassure. So the NT-proBNP is normalizing. You're a bit more reassured that at least, I guess we all can a bit argue where the NT-proBNP comes from in terms of in the ventricles, but we certainly find that the effect of the RV on the LV seems to be not as significant, and they're probably doing okay. But again, more of a trend, as you were mentioning, than an absolute value. We're starting to look at our QPQS data. We've just been doing some swaddle and bundle, and just QPQSs and some of the ASDs, and some of our ones that are, that we think are a bit, their vascular bed's a bit more vulnerable to ASD, so some of the PRENs and the syndromic kids. And so hopefully have that data that we'll be going through with our cardiac MRI team within the next few months. But just to sort of tease out, because I think a lot of us sort of go, we don't really know a QPQS, right? By gold standard, you get a cath. But a lot of times I think you get sort of, if you can get an idea of what QPQS in certain vulnerable patients might be more significant than just an otherwise normal child, that might be a little bit more helpful. Again, our numbers are going to be small, so we might have to look at incorporating some other centers, but I think it's a start to sort of look at more other non-invasive tools that can be added on to the TNE echo that's being used.
Well, and we do outputs all the time. I mean, like, outputs are easy to do. We do them in the fetus, down to about 18 weeks, and we can do them in newborns pretty easily too. So that's something that we haven't really done. I know that Abbas and Kumar and those folks are actually doing outputs more and more, but we haven't done it from a clinical perspective postnatally. It's mostly been for research purposes.
Awesome.
Something for us to look at more, Lisa.
And we can say, this is, believe the echo. I'm sure you have good fellows.
That's very encouraging. Dr. Jane, your study on the MRI stroke volume versus echo, especially for those people who don't have MRI and are wondering if the echo, like Dr. Hornberger said, believe the echo. That's certainly very encouraging. And a lot of us still tend to use the NT-proBNP, but the range is so wide that sometimes it's very difficult. And the hydration status of the baby, the clinical status, there's so many little factors that go into it. But we're certainly looking forward to seeing what the newer work provides us. I wanted to circle back to Dr. Jane regarding preemies who end up with LPD and LV dysfunction in the setting of hypertension. I just wanted to get an idea of how you would approach that kind of pathology in your unit.
Who's the wrong member in the group here to ask that question? As Lisa mentioned, I also hate it. I absolutely hate LV restrictive type of pathophysiology. I don't know how to diagnose it. I'm not entirely sure what to do with it. So, I mean, in concept, we know that diastolic function is poor, and in concept, we know when the patients are hypertensive, they probably have a degree of LV sort of hypertrophy or restriction. I personally don't know on echo whether I can do single echo and say this patient has diastolic dysfunction or not. So, and in the LA pressures, I find it increasingly hard to know in echo whether it's there high or no. And even if I suspect it, I don't know what exactly to do clinically with that information. So it's a bit of a work in progress, call it. And perhaps Lisa or Angela might know a bit better about LV restrictive pathology and how do you diagnose for sure. The obvious big ones, dilated LV, are easier ones to diagnose, but the subtle things, I struggle with it.
So real primary restrictive LV, like the myocardial restriction, as a primary diagnosis, usually they have progressively bigger LAs and RAs or LAs, whereas they're LVs of normal size and they have good function, systolic function. So people say, oh, good function. You're like, no. We undercall restriction, I think, all the time. It's now starting to be like, are we sure this isn't restrictive physiology? And it could be left ventricle or right ventricle. Because as soon as we start thinking about it, you do things different. You slow heart rates, you do this. Yeah. In the PRAM, the kind of diastolic pathology we're talking about in the early life is mostly mild. We're not talking about big time LV. I think it's something that can progress and becomes an issue as they get older and probably feeds into all of the population data that's been done in several different countries showing that PRAMs die young of cardiovascular disease. Like cardiovascular disease is just one of those things. But I don't think early on it may be mild. I don't think early on in that group of patients, it's necessarily a huge player. And they don't tend to get the systolic dysfunction necessarily, at least not the ones that we've looked at. But I do think it's a contributing factor long term, and it may not be helpful when you have shunts at atrial level. If you've got a little bit of elevated, then that's going to drive flow. And all you do is add a little duct to that, and you've just now driven flow more because you're going to increase your. I think ducts are probably not very super well tolerated if you have some restriction there too.
I think the other question was in the hypertension that these kids often have, the BPD hypertensive kids. They also, I find their systolic function appears to be okay. And then the question comes, do they have a degree of sort of back pressure phenomena contributing to their BPD? And people are debating that. And I just don't know whether there's something in echo which can tell us whether this hypertension is playing a role in lung disease or not. I don't know.
Worth looking, I guess, at pulmonary vein flow patterns. I mean, in the teens, we've seen their pulmonary vein flow patterns look like older adult pulmonary vein flow patterns. And if you have an ASD, that's not huge because those are big, you've lost that gradient. Then also it's looking at your gradient across your ASD to see if your LA pressures are high, because you should be able to do those sort of measurements as I was showing you with these other more extreme cases. But, and they have the systemic hypertension due to renal or due to kind of systemic inflammation or something else, whatever their exposures were. Is that what the thought is?
Yeah, so nobody actually has figured out why in the BPD kids tend to have hypertension, which always happen around mid-30 or late 30 weeks. The thought process is that it's the lung angiotensin II conversion dysfunction in the lungs. That's a theoretical concept people are working upon, resulting in higher sort of renin and aldosterone because not getting the feedback from the lungs, which our nephrology team is typically, apart from ruling out the structural etiology, right, renal sort of artery stenosis and coarctation, don't tend to investigate much more than that. And because in their opinion, once you give them a bit of hydralazine or some alpha blocker, after a period of time, they all come off it, their blood pressure normalizes as the lung improves. So we don't really know what the pathophysiology is.
And ACE inhibitors, just thinking also because they might have a benefit on the fibrosis of the ventricle. That's also something that people have
right.
like you see in PREMs. I don't know. We've been toying with the idea of the PREMs and giving something to make sure that they maintain lower systemic pressures, because for sure they remodel their ventricles in a bad way, and that's going to contribute to later disease. So the question is, can you do something to prevent them from having this negative remodeling secondary to higher pressures that they're seeing that they shouldn't be seeing so early in life, and whatever else contributes to it.
I know there's been some discussion about sildenafil, also the benefit of sildenafil in some of these babies, not just being primarily on the pulmonary vascular bed, but for exactly what you guys are saying in terms of affecting some of your systemic vascular resistance and potentially having a positive effect with some of that diastolic dysfunction. And it's funny because if you were to ask me about very sick pulmonary hypertension babies, I never recommend milrinone as a first-line agent, because often if you have really systemic, suprasystemic high pressures, you don't want to drop your SVR because you risk having that bowing of your septum even be worse into the LV. But I think there's a few times, especially prems with LV dysfunction, I think CDHs, the congenital diaphragmatic hernia population, there's evolving literature that actually those ventricles are not normal. And so milrinone can be a really effective strategy early on in managing those babies. I think that's why they actually do so well, which might not be the case with like a true IPH kid, for example.
Lot of data to come, lot to learn as we go along.
That's great.
Thank you so much for this really interesting discussion. We thank Dr. Hornberger, Dr. Jane, Dr. Bates. It's been really enlightening, and it gives us a lot of questions and things to improve in our daily practice. So thank you so much.